Welcome to this program on achieving and maintaining improved quality of life in patients with tardive dyskinesia. Very much looking forward to having a deep conversation with you. My name is Rakesh Jain, and this conversation about tardive dyskinesia is one that has been underemphasized for some years, but now it's time to really address it in full detail. Disclosures you have here for your own review. I also want to advise you that this was a very well-reviewed program, and it's been independently reviewed for business. And the video clips we have, which the patients were very kind to allow us to share with you, we did obtain permission for it. The learning objectives are, we're going to focus on the quality of life issues in tardive dyskinesia, and I'll describe to you the importance of the aims, and then we will look at some treatment options for this condition. But first of all, definition. What is tardive dyskinesia? It, of course, is an involuntary, abnormal movement that typically starts after long-term exposure to dopamine agents, particularly dopamine postsynaptic receptor modulating agents. So it comes with three kinds of movements: choreiform activities, althetoid movements, and rhythmic movements. And it can be very impairing, as we're about to see. So you and I are clearly experts in our field, but the real experts in tardive dyskinesia are patients. So I brought for you a collection of video clips from patients so that they can educate us on their perspectives of living with tardive dyskinesia. Let's hear them.
The tongue movements are things that are unusual, that people kind of stare at and wonder what's going on with you or why that's happening, or it embarrasses them and they withdraw or are judgmental.
I have difficulty swallowing. I cough a lot. I choke up a lot, even with water.
Living with it is not easy, especially when you don't understand what's going on and what's happening. Because it wasn't understood in the whole deal. It was hard for my family to understand what was happening to me and what was going on and why is Dad nuts.
My wife has to schedule an appointment.
Because I have to schedule his appointments.
I can't answer the phone.
You can't answer the phone. The way it's kind of impacted our marriage, it does have some negative impacts. It's kind of how I see my husband. So he used to be like my protector and my best friend, and I still see him that way, but it's taken some work to see him that way still, because when it first happened, I felt like I had to take care of him, and I felt when people were not nice to him, I had to defend him, and it went from being like this my equal to almost being like my child. And once I realized that wasn't right, it's not like just because someone can't speak doesn't mean that they're not mentally there. And so now it's just trying to get that point across to everybody that we know. And people have stopped talking to us. We have lost a lot of friends, and that's fine. It's just been really hard. So it's taken a lot of work and therapy for both of us to kind of be okay with accept what we have.
Those are very powerful stories. And as I sat across from the individuals and their family member, as you saw, hearing their plight, it became quite clear that tardive dyskinesia is not just a movement disorder. It's also conditioned with a huge amount of suffering, psychosocial impairment, and it's common. So this is a very recent head-to-head meta-analysis looking at various compounds. And what is found as the annualized tardive dyskinesia incidence with first generation is high, 6.5%. The second generations are less at 2.6%. But the problem is we're using a lot of these medications. So there's no running away from tardive dyskinesia. We're going to have to stand our ground and deal with it. The clinical course is one invariably of a slow start after some months or years of exposure. And then it, if you will, builds up. And the psychosocial impairment usually outpaces this trajectory. there's a greater and greater accumulation of life challenges that could be physical, emotional, social, financial, relationship. It can be so many different things. The risk factors are increasing age. Obviously, higher the dose, longer the exposure, greater problems. Mood disorders are an issue. And what we're now discovering is the history of previous EPS or Parkinsonism or tremors significantly increase the risk of tardive dyskinesia. As I've said more than one time before, and I will say that multiple times because it is so critical, tardive dyskinesia has significant impact on functioning and quality of life. So when we're treating our patients, what do we focus on? We focus on the abnormal movements, but we definitely need to focus on this as well. Here's a study from Joe McAvoy and his colleagues that showed that social withdrawal, mental and physical functioning, and quality of life are all adversely and negatively impacted by tardive dyskinesia. And on top of that, trying to get a job, holding down a job, all of that is further challenged by having tardive dyskinesia. This fascinating study revealed that even though we try not to be biased, there is significant bias against individuals who have these abnormal, difficult movements that even employers and no doubt fellow employees really have a concern with. So the emerging neurobiology and modulation of tardive dyskinesia has actually gone through some significant progress. And we believe there are multiple factors that impact tardive dyskinesia. So the question is, where does tardive dyskinesia live? And the thought is, even though it's the body that shows the manifestations, the main challenge may be in the dorsal striatum where the D2 receptor, the postsynaptic D2 receptor, because of chronic blockade, is really the one impacted. But there's a large number of factors that go into it. We have to know how long has that happened? What is the degree of the impact? What is the VMAT2 activity, etc. So dopamine depletion is the birth of a new mechanism to treat tardive dyskinesia. And we don't want dopamine depletion everywhere. Therefore, VMAT1 is not what we employ. We tend to employ VMAT2 inhibition because that is extensively distributed in the human brain cortex, and particularly in the striatum and basal ganglia. It is, of course, found in the presynaptic neuron. Please do remember the concept. The concept is of dopamine depletion, but targeted dopamine depletion. So how do we identify and assess for tardive dyskinesia? And the AIMS has been, and rightfully so, the gold standard tool. There are 7 body regions: muscles of facial expression, lips and perioral region, tongue, jaw. So above the neckline, there are 4 regions: upper extremity, lower extremity, and of course the truncal region, which includes the neck. The way it is scored is on a scale of 0 to 4. 0 is none, minimal, mild, moderate, and severe. A positive AIM score by general consensus is a score of 2 or more in 2 regions, or a score of 3 in a single region. This scale is not that difficult to do at all. However, it is important to be able to remember the basic mechanistic basis of it. So the preliminaries are the patient should be in a chair, should not have, like my chair actually, should not have arms. We should ask if they have anything in their mouth, if they have teeth or dentures, artificial teeth or dentures, they should be removed. And we should ask the patients before we start the exam if, since the last appointment, if they have noticed any abnormal movements. This is a rather important point because we've been trained to think of the AIMS as all objective, but it's actually a combination of objective and subjective exams. Now, you might say, I want to actually see an AIMS being done. It's all well and good to look at it on a slide. No problem. I have this video for you. I was part of creating this video some years ago, 2 or 3 years ago, And it's turned out to be very useful as a demonstration of a gold standard way of doing the AIMS examination. Here is the link for you. It's about 6 to 8 minutes long. It may be worth looking at it once or twice just to refresh your memory on how a gold standard examination is conducted. Now, telepsychiatry does bring with it some significant challenges, but also significant opportunities. So what are the challenges? It's much harder to complete a full AIMS, obviously, because video is a challenging medium in terms of, well, touching a patient, obviously, examining the whole body, watching them move across the room. Those are some specific challenges, and no guidelines exist to guide me in this process. But what about potential solutions? I have 3 to offer you. First of all, a suboptimal AIMS is better than no AIMS. Let's not use the excuse of I can't do it right, so I won't do it. By the way, having a family member or a support system member present during the appointment, assuming the patient gives full permission for it, vastly improves the tardive dyskinesia examination, particularly if the patient is cognitively challenged. And most of all, the TD exam really can be not too impacted by telepsychiatry. Most of the AIMS, most of the subjective examination we need to do can be done. So for example, the activation maneuver, that's easy to do on telepsychiatry. Asking the patient to open their mouth and to view their tongue at rest and when protruding, those are easy things to do. So let's not let the fact that today we're in the pandemic situation be a reason for abdicating our responsibility to assess for tardive dyskinesia. And part of that process is to do AIMS or something very similar to it. So in terms of diagnostic barriers and confounds, there are several because the terminology can be confusing, right? So EPS, what does that mean? And essentially, it's better not to call it EPS. It's better to call it what it is. And I have these terms right here for you, and I encourage you to review it at your convenience. Akathisia is different than bradykinesia, which is different from dyskinesia, dystonia, and Parkinsonism. And it matters what we call it, as the treatment will very much depend on what the condition is. So here's I think, a nice, elegant way to separate out the symptoms so that differential diagnosis goes much easier. So drug-induced Parkinsonism is, as I've said, quite different from tardive Parkinsonism, because idiopathic Parkinsonism, which has very clear, distinct dopamine scan abnormalities, is a different issue. So it is also important to remember that patients can have tardive dyskinesia and Parkinsonian symptoms of full Parkinsonism. So in case the presentation is exceedingly challenging, it's perfectly appropriate to get a second opinion. But it is also perfectly appropriate to appreciate that you and I, in the world of psychiatry, are actually quite competent at making the diagnosis of tardive dyskinesia in the vast majority of patients. In terms of management of tardive dyskinesia, let's look at a treatment paradigm. First of all, if you're going to choose an antipsychotic medication, it is best to choose one that may have the best fit with the patient. So obviously we keep the lowest dose for the shortest duration of time, though that luxury is not afforded to us in a number of situations. So the second best thing we can do is assess for tardive dyskinesia before and during treatment. If we do increase the dose of the antipsychotic medication, we have to be careful in terms of making sure that is necessary. 2, also making sure we reassess for any abnormal movements. And let's remember, if a patient has any movement difficulties, not tardive dyskinesia, other movement difficulties created by their antipsychotic medication, that medication is now a higher risk factor for the development of TD. If we do decide to use a suppressive medication or a treatment for tardive dyskinesia, then the level A evidence really does go to the new generation of VMAT2 inhibitors that we will talk about later. Clonazepam and ginkgo biloba get level B evidence. Amantadine is level C. And then after that, obviously, also comes deep brain stimulation. So a neurosurgical treatment is a possibility in patients with really refractory tardive dyskinesia. We have Canadian treatment guidelines that came out in 2019, and they're strikingly similar, as you can see. VMAT2 inhibitors, two in particular, obviously, Deutetrabenazine and Valbenazine. I'll tell you a lot more about them in just a few minutes. Get grade A recommendation. Amantadine here got grade B, benzodiazepines grade B, and deep brain stimulation received a grade C. As you can see, there's a striking convergence on what the global thought is on how to treat the condition. Watch out. Watch out for anticholinergics. Anticholinergics such as benztropine may be a particular and a significant risk factor for the development of tardive dyskinesia in a wide variety of patients. So the use of anticholinergics is not a problem in its own right. It is a problem if we use it for extended periods of time. So unless a patient really needs it, watch out, please. It has become a significant source of trouble. Now, you have seen this slide before, but I want to remind you one more time that dopamine depletion is the new mechanism to treat tardive dyskinesia's abnormal motoric symptoms. Just remember, we're going to work on the presynaptic neuron to deplete dopamine by blocking VMAT2 transporter. So let's compare receptor pharmacology, looking at the two FDA-approved medications, that being Valbenazine and Deutetrabenazine. Now, there are differences, and we'll look at the differences in a second. But it is important to remember that as we look at both medications, no matter how they arrive at the VMAT2 inhibition, in totality, it does appear that the receptor occupancy is about the same. So the quote, at therapeutic doses, net occupancy of VMAT2 by the active metabolites of both compounds is comparable. So let's focus on each compound differently. So let's do it separately. We'll first talk about deutetrabenazine. What is that? Well, deuterium, it's a naturally occurring, stable, non-radioactive, non-toxic isotope of hydrogen. And very cleverly, what was done is tetrabenazine, the parent compound. Can you see there's H3 and H3? So that makes it 6 atoms of hydrogen. Those 6 atoms of hydrogen were replaced with deuterium, and that created a new compound called deutetrabenazine. And you might be wondering, why do that? Well, here's a simple reason. By doing so, we are changing the metabolic breakdown. And by doing that, as you can see here, deuterium attenuates metabolic breakdown of active metabolites. Okay, so BID dosing now becomes a significant possibility. Alteration of pharmacokinetics often leads to a change in pharmacodynamics. And therein lies the reason for this particular medication. Now, the other medication is Valbenazine. Here, too, some interesting things have happened. Let's examine it. So tetrabenazine is broken down into these 4 metabolites. What actually happened with valbenazine is one of the metabolites, the one that I have put in that yellow box, actually has a prodrug, valine, an amino acid was attached to it. So it's not quite a prodrug because even the parent drug has some activity, but the breakdown becomes much slower. And by doing that, the pharmacokinetics are altered, obviously, and it becomes a once-a-day medication. So both valbenazine and deutetrabenazine are indeed VMAT2 inhibitors, but we could call them the new generation VMAT2 inhibitors, and both of them have an FDA indication. Let's look at some recent clinical trials of these VMAT2 inhibitors for the treatment of tardive dyskinesia. The first is Deutetrabenazine. Let's see what happened. This was a fixed-dose study design. This was published by Karen Anderson and her group. And here you can see that it is the 24 and the 36 milligrams per day dose given as compared to placebo that was numerically and statistically superior to placebo in reducing the AIMS score. In terms of side effects, what did we see? Well, I'll just highlight a few for you. Headache, Deutetrabenazine 5%, placebo 8, somnolence 4 versus 7, diarrhea 4 and 4, nasopharyngitis 4 and 2, fatigue 4 and 5. As you can see, quite well tolerated. All right, now we turn our attention to the other FDA-approved medication. That, of course, is Valbenazine. What did we see here? 2 doses separate from placebo, and those doses are 40 milligrams and 80 milligrams. There is a clear hint that 80 milligrams may have a greater effect, but both doses are actually effective. What about adverse effects? Here, too, we see pretty good tolerability for the compound. Somnolence, about 11% compared to about 4%. Anticholinergic effects, about 5.5% to just under 5%. Balance, 4.1 versus 2.2. Headaches, 3.4 versus 2.7. And akathisia, 2.7% versus 0.5. Both of these medications I just mentioned to you appear to be, generally speaking, quite well tolerated. But that doesn't take away the responsibility from us clinicians in actively managing these issues. And we will talk more about some of the more common ones and how we might be able to manage it. But what about long-term? Tardive dyskinesia is not a short-term problem. What about long-term? And we do have long-term data. So here's Deutetrabenazine. We have 2-year data. And I'm happy to report to you, based on the study by Fernandez and colleagues, that long-term, there does appear to be continued, in fact, somewhat increasing benefit, and there was no significant dose creep at all. So that was Deutetrabenazine. What about Valbenazine? Same thing. We saw ongoing effects. This is a study that showed clearly a continuation effect. In fact, perhaps a further improvement with the passage of time without significant dose creep. So yes, both of these medications now have short-term and long-term data. That is actually quite reassuring. And I would like for you to look at how effective these treatments can be. Same patient on the left and right. What you're seeing is she was offered medications for a few days. She took her medication for 1 single day, came back to the studio so we could record the improvement. The first day when I saw her, she actually came with a walker. That's how impaired her movement was. Day 2, her movement was not obviously perfect, but improved enough. She came without the walker. So again, just kind of demonstrates in a visual way, VMAT2 inhibitors can be very effective medications. Okay, now let's look at some potential challenges because we need to solve those issues should we encounter any problems, such as the following: sleepiness and sedation. That can happen with either one of them. The rates are relatively low, so it's best to not expect them, but to caution the patient. So should they happen, adherence is not challenged. So let's caution them before the start of therapy. Let's reduce the dose. Should sedation or sleepiness occur, we can change it to evening doses, and off-label, we can make modifications to dosing. So for example, with Deutetrabenazine off-label, I might ask the patient for a week to skip the morning dose and then obviously increase it back up. With Valbenazine, 40 milligrams is the lowest dose. Should sedation happen, I might recommend they take it every other day until the sedation has worn off. These are all temporary measures. I do want to go to approved doses, but if I don't go through these side effects and help the patient deal with them and overcome them, then adherence is significantly challenged. By the way, akathisia and EPS can occur with both of these two treatment options. The label says so, and we have seen it in clinical practice. It's not common, but it sure can happen. By the way, the same tools and techniques I just described to you would work here as well. And by the way, do ask yourself the question, did I uncover Parkinson's in this patient? That's a possibility. More often than not, it is a side effect that through the advice I gave you before and what I have here, dose reduction, slow it down, we can mitigate that side effect. Now, this is an interesting side effect. It's not a side effect. It's part of the disease process many of our patients face, which is lack of insight. And here, I have to bring the very best of myself as a clinician to help the patient gently appreciate tardive dyskinesia is present in them. Not all patients know that. But very importantly, the impact it has on them and their functioning. Sometimes I've had better luck using that as the royal road to success in explaining to patients this tardive dyskinesia is a challenge and we should treat it. Motivational interviewing skills have been very helpful. There are 3 critical issues, dear colleagues, I wish to draw your attention to. First of all, there is no need to discontinue, reduce, or change the pre-existing or underlying antipsychotic therapy. Even though that may be the reason why the patient has developed tardive dyskinesia, they may well need that medication for their betterment. Neither one of these 2 VMAT2 inhibitors require you to change that automatically. Number 2, if they're on antidepressant or mood stabilizer therapy, that is fine. And both of these medications are effective no matter what the underlying condition might be it schizophrenia or mood disorder. I'm very happy to report to you a very new development. I was one of the co-authors of this particular project. These are the new and the latest modified Delphi guidelines on tardive dyskinesia. And this came out just this year, 2020, in Journal of Clinical Psychiatry. As you can see, there are a number of well-known experts. I was lucky enough to be involved in the 11 expert group, had quite a bit of experience in this particular group, and we put out these guidelines. I'm looking forward to telling you just a little bit more about it. So first of all, screening assessments. We made a pretty big deal about what has been known for about 40, 50 years, that tardive dyskinesia is underappreciated, underdiagnosed, but this problem can be solved through screening. But good screening, which includes subjective, objective tools, asking the patient, asking the support system, but also engaging in an AIMS examination, which despite telepsychiatry, we can do quite a bit of. All right. Something else that you want to remember is we do recommend that these treatment options not be just given to the patient, but they be pulled into a deep conversation in terms of collaborative care. If the underlying antipsychotic regimen can be modified, by all means, let's do that. But in most cases, it won't be. And of course, treatment with a VMAT2 inhibitor is what is going to be recommended. The treatment approach is not to be blindly followed. We should know the severity of the TD. What are we trying to treat? Are we trying to treat just symptoms or the impairment coming from symptoms? Those are relevant questions to ask ourselves. And of course, if the patient is on current anticholinergic therapy, that may need to be eliminated. And the following should be considered. The full pharmacological treatment plan for the patient should be reviewed. And of course, we should make sure that underlying treatment with antipsychotics is not prematurely stopped. We did tackle the question of which particular VMAT2 inhibitor to use. And this is what we came up with based on the data and experience. Both of them are appropriate. However, for individual patients, one may be more appropriate than the other to begin with. So think of tolerability, safety, efficacy, and ease of use. But please be aware, should one VMAT2 inhibitor be ineffective for any reason, tolerability, efficacy, the next step is to switch to the other VMAT2 inhibitor before using anything that is less evidence-based, okay? So VMAT2 inhibitor number 1, if hopefully that'll go well, but if it doesn't, we switch to the other. All right, so those are the general parameters. So in conclusion, it is important for us to remember that screening proactively, routinely, and systematically for tardive dyskinesia is crucial, no matter who the patient is, young or old, on atypical or atypical, has a mood disorder or a primary psychotic disorder. We cannot discriminate. Tardive dyskinesia can affect each one of us. Point number 2, there have been some very innovative alterations of tetrabenazine. So we have 2 FDA-approved treatment options, Deutetrabenazine and Valbenazine, and we expect them to serve a number of our patients' needs. But what are their needs? They're a combination. They're a combination of the abnormal movement, but also the psychosocial impairment that I just talked about. And the third is significant research, including the new Delphi guidelines that summates it all, tells that we can really make an impact, not just for the short run, but also in the long run. And I really implore you to keep up with the rapidly evolving research in the world of VMAT2 inhibitors and tardive dyskinesia. And I'll end with this one final very important comment, that improving functionality in our patients with tardive dyskinesia is a major goal of treatment. Thank you very much for letting me present to you, and I'm looking forward to a vigorous Q&A. Thank you.